Hello and welcome to my channel. In this lecture we'll be discussing the posterior abdominal wall. It's the first lecture in 4 lecture series about the posterior abdominal wall. So let's begin. We'll start with the vertebral column. The lumbar vertebrae are 5 in number, of course, as you know, and the body is I think we discussed this before. It's kidney shaped, as you can see here. And the articular processes, it's one way to know that this is a lumbar vertebra. See the articular processes directed backwards and medial. See that? Now these other vertebrae, see, backwards and lateral, backwards and lateral, backwards and lateral. All these are thoracic vertebrae to be compared with the lumbar vertebra. But I urge you not to depend on the fact that the lumbar vertebrae are larger than other vertebrae, because if you are in a practical exam, you will be encountering only the lumbar vertebra. There is no other vertebra to compare with. So know your anatomy. The body is kidney shaped, and the articular processes are directed backwards and medial. The spine is broad and straight backwards, and the transverse processes are slim and to the lateral sides, of course. These are the criteria by which you know that this is a lumbar vertebra. I want to remind you of the different parts of the vertebra. This is the body. These are the pedicles that connect the body to the to the 7 processes posterior, which are the 2 transverse processes, 2 upper and 2 lower articular processes, and the spine. Now, connecting the spine with these structures is the lamina. See, this is the lamina, and lamina, they do a laminectomy if you're going to operate on the spinal cord. You start your operation with a procedure called laminectomy, in which you cut the lamina to have an access to the spinal cord. So these are the lumbar vertebrae. The intervertebral foramina, as we studied before, formed by the adjacent vertebra, like an upper and lower vertebra. In this case, for example, this is the intervertebral foramen, as you can see here. It transmits the spinal nerve, a spinal artery that goes inside and supplies the spinal cord, the dura mater, the sleeve around the beginning of the spinal nerve, with the arachnoid mater lining it with some CSF. So the nerve comes out with a short sleeve of dura and arachnoid and CSF around it. Remember this, because we will use this fact in interpreting a myelogram. And also it transmits a venous connection between the inside venous plexuses and the outside, the external vertebral venous plexus connected to the internal vertebral venous plexus inside the vertebral canal. See, I brought you 2 plain x-rays, one side view and one posterior anterior view. See that? To identify the different structures of vertebrae. This is the body, of course, you know the body. These 2 circles are the cut section of the pedicles. So remember how the pedicles look like in the posterior anterior view. This is the pedicle in a side view, complete pedicle. But here you see only the cut section of the pedicle. In the middle, this shadow is for the spine. See, these are the spines of vertebra. These are the pedicles, and the transverse processes, of course, to the lateral side. They are faint here. Here you see the cut section of the transverse process as a circle. This is a transverse process. This is another transverse process. You see the full spine, and you see the full pedicle and the intervertebral foramen, and here the disc, of course, between vertebrae. Okay, now for the joints between the vertebrae, they articulate in different sites in the articular processes and between the bodies. Between the bodies, there's an intervertebral disc, which is composed of fibrocartilage. The arrangement of the fibrocartilage in circles, as you can see here, this is the annulus fibrosus. This is the fibrous component, annulus fibrosus, fibrocartilage layers, as you can see clearly here. And in the middle, there's a cushion-like nucleus pulposus, which is a mass of gelatinous material, acts as a cushion to absorb, the weight of the body and distributes it to the circles of the disc for the proper distribution of the body weight on these vertebrae. So remember the components of the intervertebral disc, please: the annulus fibrosus and the nucleus pulposus. Now, in case of faulty weightlifting, like lifting a heavy weight, while the vertebral column is in flexion, picking up a heavy weight from the ground without kneeling, without using your thighs and knees, this exerts a tremendous pressure on the annulus fibrosus, especially at the peripheries, where the vertebra, press on these parts. So a case of disc prolapse occurs in which the part of the annulus fibrosus gets torn, especially the posterolateral portion of the annulus fibrosus, and what happens is that the nucleus pulposus bulges backwards from this tear, and most common is posterolateral direction, okay, but still in the vertebral canal, so compressing the roots of the spinal nerves, and this explains the shooting pain. If it's in the lumbar vertebrae, the shooting pain in the thigh along the rootlets of the sciatic nerve, which is most commonly involved in these encounters. So remember the disc prolapse, it's not prolapse of the whole disc, it's a tear in the nucleus in the annulus fibrosus that results in the bulge of the nucleus pulposus and compressing the related rootlets of a spinal nerve. Okay, and these are articulated vertebrae, as you can see here, between the bodies and between the articular processes, as we studied before with the cervical and thoracic vertebrae. These are the zygapophyseal joints. They are of the synovial plane type. Plane synovial type allows some gliding action between the vertebra, adjacent vertebra. These are the zygapophyseal joints between the articular processes. You see here, it's very clear here. Okay, now for a joint we need ligaments to hold to keep the joint intact. So we have a series of ligaments. On the anterior aspect of the bodies, we have the anterior longitudinal ligament. As you can see here, it's continuous upwards. Remember how it ended in the cervical region as the anterior atlanto-occipital membrane, but we're not discussing the neck now. So here in the lumbar region, it's the anterior longitudinal ligament at the anterior of vertebrae or anterior of body of vertebrae. It's the same, but it's not the same with the posterior longitudinal ligament. The posterior longitudinal ligament is at the back of the bodies of vertebra, means inside the vertebral canal. If you said at the back of vertebra, so it means on top of the spines, and this is the supraspinous ligament. Don't be confused with the terms you use. Okay, so this is the posterior longitudinal ligament at the back of the bodies of vertebrae, and it's one of the contents of the vertebral canal. Here it is, the posterior longitudinal ligament. Also, we have the ligamentum flavum, which is the yellow ligament. It means the yellow ligament. It's yellow because it has an 80% elastic fibers and 20% collagen fibers. So it's elastic and it's interrupted ligament. It's not continuous like the anterior and posterior longitudinal ones. See how it's interrupted? It joins the lamina of adjacent vertebrae together. Joins the lamina of adjacent vertebrae together. This is the ligamentum flavum. Also, we have the supraspinous ligament on top of the spines. We have the interspinous ligament between the spines, filling the gap between the spines, and the intertransverse ligament, which is between the gap, fills the gap between the transverse processes. So you have the supraspinous ligament, intertransverse and interspinous ligament, as you can see here. And this is the ligamentum flavum. This is the posterior longitudinal, anterior longitudinal, and the intervertebral disc. Another ligament, essential especially for the lumbosacral joint, the joint between the last vertebra and the first piece of the sacrum, is the iliolumbar ligament, as you can see here. It has two components, the iliolumbar and lumbosacral ligaments. We will study this in detail with the pelvis, but since it involves the fifth lumbar vertebra, so it's part of our posterior abdominal wall, the iliolumbar ligament. And remember, it gives origin to the quadratus lumborum muscle that we will be studying with the posterior abdominal wall, iliolumbar ligament. With the joints in place and the vertebra articulating together in place, the vertebral column as a whole shows different curvatures. See, an anterior curve, convex curve, anteriorly occurs in the cervical region and the lumbar region, and a concave curve in the thoracic region and the sacral region. Now, they call the sacral and thoracic curvatures the primary curvatures because these are the first curves to occur in the vertebral column during development. The whole vertebral column was curved, concave anteriorly. So this is the primary curvature. But with the growth of the body intrauterine and the viscera starts to develop, so weight is exerted on the vertebral column, so it assumes two other curvatures, anterior curvatures, convex curvatures that occur in the cervical region and in the lumbar region. These are called the secondary curvatures. Secondary curvatures. Now, if the curve of the lumbar region increases, as in women, for example, wearing high heels or with pregnancy, multiple pregnancies, this curve is exaggerated forwards, increased forwards, more convexity. It's called lordosis. Lordosis. Lordosis means increase in the convexity of the secondary curvature that occurs in the lumbar region. See that? It becomes more convex anteriorly. So don't forget lordosis. We're done with vertebrae. Now we'll go inside the vertebra to have a look at the spinal cord in the lumbar region. We'll be dealing with all of the spinal cord with our study of the back. But now just a hint about what's happening down there in the lumbar region, because there is an important lumbar cistern I want to talk to you about. Now, the spinal cord shows enlargements in the region of plexuses like the brachial plexus, the lumbosacral plexus, because plexus means more cells, so more size in the spinal cord. This is in the lumbar region, the lumbar enlargement on the lumbosacral plexus. It ends by as a conical part of the spinal cord as conus medullaris, and this conus medullaris, it doesn't mean that the spinal cord fills the vertebral column. No, the spinal cord ends at the level between L1 and L2 vertebrae. So from L2 downwards till the last sacral piece, we have no spinal cord. We have only roots of nerves. Remember this. Why? Because when we study the coverings of the spinal cord, there will be a space called the lumbar cistern, in which you may introduce a needle for administering a drug or taking a sample of the CSF, whatever. But remember, it's between L1 and 2 that the spinal cord ends. Also, in children, it's slightly lower because it's still not completely not the adult size. So you put this in mind if you are, for example, want to diagnose a meningitis, for example, and you want to take a sample of CSF from a child. Remember that it ends at L3 level instead of L1 and L2. So you go further down to obtain your sample of the CSF. Now, the region of the spinal cord that gives rise to a pair of spinal nerves, this is a spinal cord segment. And this is what we refer to when we mention a root value of the nerve. Root value of the nerve. The phrenic, for example, is C3, 4, 5. So it means that C3 segment and C4 segment and C5 segment, the nerves arising from these segments give branches to form the phrenic nerve that supplies the diaphragm. So remember this. This is a spinal cord segment. And as you can see, the nerve arises with rootlets first, and then they unite to form the root. There is an anterior root and posterior root, or ventral and dorsal roots. And you see a bulge on the dorsal root. You see this bulge. This is the dorsal root ganglion. Dorsal pseudo-unipolar cells that one end they receive impulses from sensory impulses, and the other end they give it to the posterior horn of the spinal cord. The spinal cord arrangement in the way that the white mater is at the periphery and the gray mater in the center. The brain was the opposite. The gray mater was at the periphery and the white mater in the center. Remember the lectures on the basics of the brain anatomy studied with the head and neck. So this is easy to, of course, you know this arrangement of the spinal cord. A cut section of the spinal cord, of course, we will not study in detail, but just to show you that the gray matter differs from different regions of the spinal cord. This is cervical. I know that because it shows a shelving here. And the posterior horn is not as thick as this one. This is a lumbar region, thick anterior and posterior horns. This is a thoracic region. It's, a straight H, in which the anterior horn is equal in thickness as the posterior horn. And this is the sacral region. See how big are the anterior and posterior horns. But I want to draw your attention to this collection of cells. See that? You have anterior horn, posterior horn, and an intermediate mass, or lateral horn. Intermediate or lateral horn. Now, you don't see this in all sections of this, all parts of the spinal cord. You see these only in segments from T1 through L2. T1 through L2, and it's responsible for the sympathetic output of the spinal cord. Remember the white ramus communicantis we talked about? It arises from this mass and goes with the ventral root, and you know the story where it leaves the nerve and forms the sympathetic chain, and gray rami communicantis from the sympathetic chain back to the nerve. Remember these facts. But in the sacral region, we have from S2 through S4, another lateral horn. See this lateral mass? This is not for sympathetic output. This is parasympathetic output. This will form the S2, 3, 4 nerves, which are called the nervi urgentus, that supply the pelvic viscera and responsible for micturition and defecation. The lateral horn in the sacral region, S2 through S4, is different, totally different than the lateral horn in T1 through L2. Please don't forget this and don't confuse these together. Okay, so in the lumbar region, the part we are studying now, only in the upper two lumbar segments you will find the lateral horn, and maybe in the third one, but the fourth and fifth, definitely no horn, as you can see here. See, there is no lateral horn. This is a lower lumbar section. Lower lumbar section. Okay. The vertebral levels of the spinal cord segments, because I told you it ends at the level of between L1 and L2, so it's definitely shorter than the vertebral column, and that's why, by the way, the upper roots are horizontal, but as you go down, they get stretched by the overgrowth of the vertebral column. It pulls the nerve roots with it, and as you go down, the nerve roots become oblique and vertical at the end to form what's so-called the coda equina. We will see that when we enter the coverings of the spinal cord. Now, at the cervical region, if you are at vertebral spine, any vertebral spine, add 1 to it, so that's the spinal cord segment. If you are, for example, at C4 spine, you are at C5 segment. If you go to thoracic region, add 2. If you are at T5 segment, you are at T7 segment of the spinal cord. Lower thoracic, add 3 plus 3. Means that if you are at T8, for example, it's T11 segment. At T11 vertebra, you are at L3 segment, and T12 vertebra, you are at S1 segment. And L1 and L2, between L1 and L2 vertebra, there is no more spinal cord, only the conus medullaris, which is the last sacral segments and carry the last sacral segments and the coccygeal segment. There is only one coccygeal nerve. Okay, the coverings of the spinal cord, we're going from out inwards. This is the dura mater covering of the spinal cord. See, the dura encloses the spinal cords and sends sleeves around the spinal nerves emerging from the cord. Sends sleeves with the lining arachnoid and CSF, so the sleeves goes slightly outwards with the nerve, and then the dura fuses with the epineurium of the spinal nerve beyond the foramen. There is an epidural space in which it has connective tissue and has the internal vertebral venous plexus I told you about around the cord, and a subdural space, which is a potential space filled with with a film of serous fluid between it and the arachnoid, but actually it's a potential space. The arachnoid does not adhere to the inside of dura, but there is this potential space filled with the film of serous fluid. So this is the dura mater we're talking about here. It ends at the level of S2 level, but an extension of the pia, which is the filum terminale, pierces this end of the dura and goes to the back of the sacrum to fix the spinal cord. We will talk about this now. This is the arachnoid mater adhering or lining the dura mater. It goes with the dura mater and ends at the same level. S2. When you open it, now you can see the lower roots of the lumbosacral plexus. See that? How the roots are oblique, almost vertical and long. See that? It resembles a tail of a horse. Cauda equina. Cauda equina, a tail of a horse, which are the roots of the lower spinal nerves that forms a structure that resembles the tail of a horse. But in the middle, see, this is the conus medullaris. This is the conus medullaris, the end of the spinal cord. And this extension, see that? This is the flavum terminale. This is not a nerve. This is a dural, pale fold upon itself to form a cord-like structure, a cord-like extension of the pia to form what's so-called the flavum terminale. Now you have a flavum terminale internum, and it pierces the dura and arachnoid and goes outwards, downwards, to the back of the coccyx as the flavum terminale externum. So you have a flavum terminale internum, flavum terminale externum. The reason you have these, we'll know when you study the pia mater. Pia mater, see, it sticks on the spinal cord. It's not a lining of the arachnoid. It sends lateral extensions, as you can see here. See these lateral extensions? Now, please, doctors, don't confuse this with the spinal nerves. Actually, the extensions from the pia between the spinal nerves. Between the spinal nerves. They are not with the spinal nerve. See, it goes laterally to attach itself to the dura. This is called the ligamentum denticulatum, or denticulate ligament. Why do we have a flavum terminale from the pia and denticulate ligament? This is to fix the spinal cord in place. Upwards, it's an extension of the pardon me. Upwards, it's an extension of the medulla oblongata. Downwards, it's pinned to the back of the coccyx by the flavum terminale, and to the lateral sides by the denticulate ligament. This ensures that the spinal cord always remains in the center while the vertebral column is moving. So remember this: the denticulate ligament and the flavum terminale to fix the cord in place, and both are extensions of the pia mater. Now I brought you a myelogram, this beautiful myelogram, in which they introduced a dye into the lumbar cistern. The lumbar cistern actually is this space, the subarachnoid space in this region that contains the coda equina and contains no spinal cord. So it means that it extends between L2 vertebra and S2 vertebra. This is the area you will work upon. Of course, you can't work on the sacral region because the vertebrae are fused. So you have only between L2 and S1 to introduce the needle, either to administer a drug or withdraw a specimen or take a sample, or for anesthesia. Anesthesia, especially in labor, they introduce the needle in the lumbar cistern. See? So they injected a dye and took a picture. Now I want you to think about this. What are these extensions that resemble a denticulate ligament? See that? These are not the denticulate ligament. These are the sleeves. I told you that the spinal nerve take with it on its exit from the vertebral canal. So don't confuse this picture of myelogram with this one. These dentations here are from the denticulate ligament, and here they are the sleeves of the spinal nerves that contain CSF. So remember this. These are totally different, although they look alike. But don't get confused if you are asked on a myelogram or you are asked on a specimen of the spinal cord. Okay, about the arterial supply of the spinal cord, it's a long organ, long structure, so it takes from all the nearby arteries like the vertebral, the deep cervical, the intercostals, the lumbar, the lateral sacral. The lateral sacral one that supplies the cauda equina. See how these are lumbar nerves. No, sorry, we are in the thoracic region, so this is an intercostal artery. Gives a branch, see, a spinal branch. We discussed this before in the when studying the thoracic wall. This branch goes inside the intervertebral foramen and divides into what's so-called the radicular arteries, anterior and posterior radicular arteries that forms a plexus to supply the different parts of the spinal cord. Remember the radicular arteries. For the venous drainage of the spinal cord, the same radicular veins. We have anterior and posterior radicular veins, but they come from tortuous columns of veins on the spinal cord itself, and resemble a connection between or act as a connection between the inside plexuses and the outside plexus. In this case, we are still in the vertebral canal. This is an internal vertebral venous plexus, which is also connected with the external vertebral venous plexus. Now, why am I telling you this? Because anything that connects with the vertebral venous plexus, this means it's a potential route for metastasis, tumor metastasis, especially lower down in the pelvic viscera where you have the prostate. There's a prostatic venous plexus connected to a vesical venous plexus around the urinary bladder, and both of them, especially the prostatic, connect to the external vertebral venous plexus and from it to the internal vertebral venous plexus. And that's why in cases of advanced cases of cancer prostate or prostatic carcinoma, there is metastasis in the vertebral column, and you can detect it by an X-ray. This is, of course, a late stage and inoperable stage in which the tumor metastasized. Okay, so we started with the bony structure of the posterior abdominal wall, the joints, and what's inside, which is the lumbar part of the lumbosacral part of the spinal cord. Next lecture we will be discussing the fascia and muscles and so on until we complete the whole 4 parts of the posterior abdominal wall. I hope you got the maximum benefit from this lecture, and thank you very much for watching.